all my respected seniors and my colleagues, I get started with the topic without any delay. So thin endometrium, do we have a solution? Now the endometrium is basically the soil to the human embryo, the seed. Now I will take my talk in the following manner, touching on these points. The endometrium is the inner epithelial layer of the uterus. And the endometrium is the inner epithelial layer of the uterus, and this responds to cyclical changes of the estrogen and the progesterone. Now, successful implantation in IVF, it requires high quality embryos, a good receptive endometrium, and a good embryo transfer technique. Now, endometrial thickness has been, it is a very important factor for success in IVF. Also, there's this concept of endometrial receptivity. Now, this is ideal in the period of window of implantation, which is usually 20 to 24 days in a 28-day cycle. Now, thin endometrium is rather alarming to us IVF specialists. Now, what is the definition cutoff? The definition cutoff given is based on various studies. In a frozen endometrium, in a frozen embryo transfer cycle, it should not be less than 7, and in a fresh, it should not be less than 8 mm. Now, the incidence in IVF of thin endometrium is not as much. It's only 1 to 2.5%. But when we talk of ovarian stimulation cycles or IUI cycles, they can be even as much as 40 to 60% plus. Although we have improved so many aspects of IVF, but still your implantation is still a roadblock. Now let's start from the basic, trying to understand the anatomy of the endometrium. Well, there's a functional layer and a basal layer. Now the functional layer is further divided into stratum compactum and stratum spongiosum layer, and then there is the 1/3 is your basalis. Now what is the importance of the functionalis layer? This is important for our embryo to implant. And this is the site where you have, the proliferation of the glands, the secretions, the growth of the vessels happening, and also this also degenerates finally. And the basalis, this provides the regenerative endometrium after the menstruation. So if you have a damage happening to the basalis layer for any reason, then you can think that you are actually at a dead end, and there is possibly you can't help the patient much. Now, physiology of endometrium is a lovely synchrony right from the hypothalamus to our target organ, the uterus, the endometrium. Now, this is all basics, but let's do a quick revision. From the hypothalamus, your GnRH is released in a pulsatile fashion. That, causes a rise in the FSH in the first half of the cycle. And because of the effect of the FSH, our follicles in the ovary, they begin to grow. And probably one becomes a dominant follicle. Then there's a mid-cycle LH surge happening. That causes this dominant follicle to ovulate and release the egg. Because of the effect of the, the FSH happening on the follicle when it's growing, the growing follicle releases estrogen. This estrogen in the first half acts on the endometrium and brings certain changes in the endometrium. Post-ovulation, the predominant hormone is your progesterone. And so post-ovulation, progesterone acts on the endometrium and brings certain changes in the endometrium, which I will just explain to you. Now, because of the effect of estrogen in the first half, what is happening is that our endometrium is relatively more echogenic to the myometrium, as you can see. So this is because of the glands, the blood vessels, the stroma. Now, it has a hyperechoic, basal layer, then an inner hypoechoic functional layer, and in the middle again you see one hyperechoic interface. So this is your typical triple multi-layered triple line endometrium that you see. Now this usually seen before ovulation happens. Once ovulation happens in 48 hours, this look disappears. This trilaminar look will disappear. Now, because of the release of progesterone in the second half, you will again see certain changes happening in the endometrium. It becomes thicker, more echogenic because of all the glands being filled with secretions, the edema, the spiral arteries growing, and this is how it looks. So it becomes much more hyperechogenic. Now, why should we understand this? Because ultimately when we make a diagnosis, if we are not familiar with how our endometrium looks in the different phases of endometrium, we may not be able to pick up these subtle changes. Of course, a thin endometrium will look super thin, but we should know these basics about our endometrium appearances. Now, what is the pathophysiology operating which results in a thin endometrium? And of course, we know that a normal endometrium leads to a successful implantation and a pregnancy, and a thin endometrium will result in implantation failure. So we should also know what is basically operating here. Definitely, there is very poor growth of the epithelium, the glands, the stroma, everything is compromised. They also say that a high uterine blood flow impedance causes thin endometrium.
I think some internet problem. I think she'll be able
And
to.
ultimately, you
Yes.
end up with a thin endometrium. Now, let's look at some of the common causes that cause thin endometrium. When you have low circulating estrogen levels, use of clomiphene, prolonged use of oral contraceptive pills, progesterone, vascular incompetence, inflammatory causes. Very specifically in our country, as Madam had and Sir mentioned, that TB. So, female genital tract TB is a very common cause of you having thin endometrium. Then chronic endometritis can be a cause. Iatrogenic, if you've done a DNC, which was too aggressive, a myomectomy that ended impacting our endometrium, cesarean section, post-polypectomy. Then, of course, certain systemic diseases, substance abuse, smoking, and a certain segment, idiopathic. Symptoms can be, irregular periods, scanty periods, infertility, of course. That is what we are interested in. Now, to understand, we should also know how to evaluate an endometrium. Now, just talking of the symptoms, causes is not going to help us. We, of course, take the history from the patient. Then we, of course, our first tool in infertility is our TVS. So we start with a 2D ultrasound. So using a TVS probe on an empty bladder, we should focus on the uterus such that 2/3 of the uterus is visible on our screen, and from the fundal tip all the way up till the cervical canal, the endometrial stripe is being seen. And then you should measure the thickness of the endometrium about 1 to 1.5 centimeter from the fundal tip. That thickest area is going to give you the thickness of the endometrium. Now, many times you may not be able to measure the ideal measurement is not possible. Reason being, the patient can be, the body habitus is obese, there are fibroids, there are polyps, sometimes, contractions. So contractions, in fact, uterine contractions can bring about a change of as much as 3 to 4 millimeters in the measurement. And whenever you encounter a thin endometrium, please repeat the measurement. That is required. That is an important step. Now, other than looking at the morphological or the architecture of our endometrium, the triple line and the thickness, another tool that we use is the Doppler, and this is used to assess the blood flow in the various zones. So these have been categorized such as zone 1, zone 2, zone 3, zone 4. As these particular pictures I've shared here, they show you how the spiral arteries, they eventually penetrate, and you can look at the zonal flow. So as the endometrium becomes more receptive, you will see that these spiral arterioles, they penetrate towards the midline, and you get a better zonal flow. Now, zonal flow is associated, or there is a correlation with positive pregnancies. So zone 1 is when the vessels have reached only the hypoechoic endomyometrial junction. Zone 2, outer hyperechoic line of the endometrium. Zone 3, intervening hypoechoic area, and zone 4 is when it is touching the median hyperechoic line. Now, this, having said, this is the basic that we must do, seeing a 2D ultrasound and a Doppler. Hysteroscopy, do we do as a first line? All the practice recommendations do not suggest that you should do it as a first line. But when you're encountering thin endometrium, you should definitely go ahead and do a hysteroscopy. That may, give you some surprises. Like I had a patient who had repeated thin endometrium, and it appeared something like this on a hysteroscope, on the hysteroscopic, view. So she had history of previous DNCs, and I was wondering why she's not really, increasing her endometrium. So there were additions like these, and subsequently, after the hysteroscopic, adhesiolysis, I have started her yet another cycle. She developed better endometrium. Right now, she is even 9 weeks pregnant. So you should look for additions like this post a procedure or post TB. You can have Asherman syndrome where it may give an appearance like this. Chronic endometritis, usually very hyperemic micropolyps. You may see all of this. Now, after hysteroscopy assessment, and along with hysteroscopy also, you should obviously take the sample and send it for TB assessment many a times, depending upon what the hysteroscopic view appears to be. Because again, TB is a very, very commonly found entity in our country. So whenever the hysteroscopic appearance is probably a case where you are suspecting, COX, then you should definitely take the endometrial biopsy or aspirate and send it for the microbiological test, CB-NAT, gene expert, or TB, PCR, TB culture. Now, chronic endometritis is also another entity which Surveen ma'am will be taking. This leads to altered endometrial receptivity and a dysbiosis. It is usually incidentally discovered on a hysteroscopy. As I mentioned, hyperemia will be there, micropolyps, and mucosal edema. And you take the endometrial biopsy and it has to be sent for a histological analysis to confirm the diagnosis. Now, why is thin endometrium important to us as IVF consultants? Live births have in fact been even reported with something as thin as 3.5 mm. Though of course, these are just random happenings. There are certain recommendations that we must follow and which are again evidence-based. So the Canadian Fertility and Andrology Society says that in fresh IVF embryo transfer cycles, the endometrial thickness less than 8 mm will have a negative impact on pregnancy and live births. And in frozen embryo transfer cycles, any thickness less than 7 mm is going to have a negative impact. This particular chart, you can see that when the endometrial thickness is between 8 to 10, you have the highest chemical and clinical pregnancies happening. Thereafter, you see a fall. Now, how should you go ahead and treat thin endometrium? Thin endometrium has to be treated in a holistic approach. So first, you should always tell your patients to have the lifestyle modification and whatever natural methodologies you can offer to your patients. Because everything starts from a healthy lifestyle. So ask your patient to eat healthy, exercise, sleep well, less stress, and the various aspects of holistic lifestyle have to be the first step of introducing them to the improvement of thin lining. Then as clinicians, we have a lot of things in our, supposedly a lot of things in our kitty. Though evidence would say otherwise, we use them pretty often, all of us who practice IVF. Now this particular list for thin endometrium, exogenous estrogen, tamoxifen, low dose aspirin, sildenafil, pentoxifilin, L-arginine, GCSF, all of this PRP endometrial scratching is something we're all familiar with and we all use. So, but I have to share with you what evidence is. Now, I thought that rather than going into the details of what is the dosage and the mechanism of action of each of these drugs, because that is something so many people take in their talks. And this is something we who practice IVF, we are well aware of how all of them are given. So my attempt today was to take the audience through the evidence support. What does the evidence say about use of all of these? Now again, I'm going to basically quote from Canadian Fertility and Andrology Society. They say that in any ovarian stimulation cycle, now these are recommendations. Recommendations are something that are based on studies or, but the recommendation, whenever it is weak, they will obviously not hold as strongly. So for ovarian stimulation cycles, most of the recommendations that we have are weak. And what is the synopsis? Now, they say that a patient with thin endometrium, they should be counseled that it may have an effect on pregnancy rates, it may not. So it is unclear, number one. Number two, there is no sufficient evidence that you recommend any stimulation protocol change. Changing a protocol a certain way is not going to enhance the pregnancy rate. This is another point. Then third one is that any adjuvant recommended to you improve endometrial thickness, again, does not need to be recommended. There is insufficient evidence for that also. So bottom line being that for your normal ovarian stimulation or your IUI cycles, just make your patient aware that even if the endometrium is thin, it may not really have an impact on the outcome of a good pregnancy, and we need not do something, go overboard with add-ons to help them such that they have a pregnancy. Now, in fresh IVF embryo transfer cycles, what does evidence say? Here, evidence says, strong evidence for this, as already spoken, that lining should be more than 8 mm. Okay. However, whenever there is a thin endometrium, you should try and recommend
Whose internet is probably weak.
Hello?
Yes, we are. Your internet had gone a little bit. So go ahead.
Okay. Okay, ma'am. Okay, ma'am. So then in the frozen embryo transfer cycles, evidence again is strong for the cutoff of your 7 mm being the endometrial thickness. So this is something that we should adhere to. Never do a transfer unless you get a 7 mm thickness of the endometrium. What we can tell our patients is we may have to cancel a lot of cycles whenever the endometrium lining is thick. We do try various combinations of, the estrogen preparations plus our aspirin plus our sildenafil, which again, as I will tell you later, evidence does not support. But point is that we should not go ahead and do a transfer if our lining is less than 7 mm. We may have to cancel multiple cycles, but if we persist, of course, we have to be mindful of the fact that we are not incurring so much of cost for our patients. But this is the general recommendation. Now, is a natural cycle better than an HRT cycle? Again, the evidence is weak, but they say that in ART treatment, there is insufficient evidence that either a natural cycle or a hormone replacement cycle for endometrial preparation will provide you better pregnancy outcomes. Now, evidence on adjuvants. So your adjuvants are aspirin, adjuvants are sildenafil, GCSF, HCG, pentoxifilin, PRP. Now, all of them have got no strong, robust backing by any study. All weak evidence in support of these use of these adjuvants. Again, ESHRE also, I wanted to quote a few recommendations from ESHRE as well, especially when it is concerned with your endometrial receptivity tests. These also lack any evidence. They say that, there is lack of clear benefit, so we do not recommend. PRP, which we use so commonly now. Now, I'm sure the audience again knows, but if I can quickly run through how you make PRP preparations in IVF, you usually do an autologous PRP. You draw about 20 ml of blood from the patient, okay, and you will take, about, let's say you divide it into 2 parts, and you mix it with a pre-prepared PRP, a certain vial, 1 ml of that, and your blood. Like 9 ml blood and 1 ml of this PRP pre-prepared vial, some concoction there, and then you do a centrifuge of this for about 10 minutes at 1500 RPM. Now, once this is centrifuged, all your blood RBCs will settle at the bottom, and your plasma will be on the top. Now, remove this plasma, discard your red blood cells, And now using this, plasma, you again centrifuge at 3000 RPM for about 10 minutes again. And then you will get a certain, the platelets will deposit at the bottom of the conical tube. Now take these platelets, okay, zero point 0.5 ml of this is infused into the uterus using your IUI cannula. We also follow another thing, that this, ultimate deposit of the platelets that we get, we do a freeze thaw freeze for about 3 times, such that all the, the vasoactive or the growth factors are released from the platelets. So basic principle of using PRP is that they have these growth factors in them. But again, though we are using it, but what evidence says is that it should not be recommended outside strict research protocols in infertile women. Now, this recommendation is from the ESHREs. So they are also saying that please do not do it, but we here in India are doing it. Endometrial scratching, again, has got no support from ESHRE. They say that routine use of endometrial scratching also should not be done. Same applies for any intrauterine installation of HCG or GCSF. So all of these world bodies like ESHRE, your HFEA, none of them say that you should do this. Now you also have this HFEA traffic light scoring. Now all this is of course UK based. They say that even your endometrial scratching is in the amber zone. If you talk of your, anything which is related to endometrial scratching or your amber, which means conflicting clinical effectiveness. So they do not recommend. But what will be our practical takeaways on the add-ons? The bottom line is that we in India, when our patients persistently land with thin endometrium, it is something, first and foremost, is your estrogen. Estrogen is the mainstay of our building up the endometrium. A standard doses, you start with 2 milligram twice a day, and then you gradually increase it. So the one important point is that you can increase the duration of giving estrogen. You need not have it. Usually we do not go beyond day 21 or day 22, for increasing our endometrial lining. We say, okay, if the lining is not reached up till 7 or 8 mm, usually 8 mm, as we said in frozen embryo transfer cycles, if it does not reach 8 mm, we say, okay, cancel the cycle. But they say that if it might take a little bit longer, and some of the seniors here might have an experience with this as to how long they have taken their cycles if it does not build up by, I usually take a cutoff of about 21, 22 days. I do not go beyond that. So now if your endometrium does not end up reaching 8 mm till then, cancel the cycle. However, before that, you can keep increasing it to TDS and sometimes 2 tablets thrice a day and so on. Another thing that is suggested is that you can change the route of administration. Now, if the oral medication is not working, please give them a transdermal gel of estrogen, or also give them some intravaginal suppository. That might help. So changing the route may also bring about greater effectiveness for that patient. Now, other than the estrogen, of course, all the other adjuvants, your aspirin, which we usually give in a dose of 75 milligrams, some people give it in a dose of 150 milligram once a day. Then you have your L-arginines, these sachets, which you basically, again, they tend to be acting like vasodilators. So you give them once or twice a day. Then you have your sildenafil, which is given intravaginally, 25 to 50 milligram once or twice a day. So we all have our different preferences with the dosage, with the, the combinations. But some of the others which we commonly use are, your tocopherol, then along with Trental. And if all of this again does not help, none of these has helped us, then last step for us would be to infuse your, using your intrauterine catheters. We infuse PRPs on day 9 and day 11 sometimes. And along with that, some people recommend use of GCSF. also intrauterine installation. But as I said, evidence doesn't support it. Bringing about. Um, and there are just some a little few minutes on the experimental treatment modalities that may come up in the future. Growth hormone, they say, might be used. It releases all your growth factors and it acts on the endometrium and it may help. And then of course stem cell treatment, which you derive from various sources from the body. So it helps, like if you instill it into the ovaries where there is premature ovarian insufficiency, that could be done. But in the case of a thin endometrium or Asherman's, we are either doing, infusing it into the uterus, or hysteroscopically we are going and injecting it into the endometrium or subendometrially. And what can be the sources of our stem cells? These can be your adipose tissue, the bone marrow, the umbilical cord, the endometrium sometimes, and the menstrual blood also. So you can derive your stem cells from all these sources. And they're also studying use of, mesenchymal derived extracellular vesicles. Now these are basically exosomes, which will be, helping in the regeneration, tissue regeneration and immune modulation. So this is the future, they are working on that. And then they say that tissue bioengineering, that is, you probably, create a scaffold with these cells and you create a lining, and that will somehow be the future. But this is of course as we go forward. My only conclusion and my only takeaway from the entire talk or attempt on the talk today is that we have certain methodologies to help us, like PRP, like GCSF, like the futuristic things. But as per evidence, they are all experimental. We in India tend to use them. We tend to use a lot of add-ons so that we can help our patients. We tend to use PRP. We tend to use GCSF. We usually, in my practice, we do hysteroscopy only when we are facing a thin endometrium, not as a first line. If ultimately the endometrium does not respond, sometimes we have to take a decision to do a transfer at a less than optimal thickness. I've had patients where I've had to do a transfer at 6.57 mm, 7.5 mm, and God has been kind. We have been able to get pregnancies in some of them. But this is only when persistently the endometrium is thin, despite all that you can do. Usually, and the practice point is that it should reach 8 mm. Before that, we should not start a progesterone and we should not do a transfer. But very rare cases where we are repeatedly getting thin endometrium, there probably we may have to take a call on doing a transfer at a lesser thickness. And if at all our endometrium is severely damaged beyond repair, the basal line is damaged, then our only resort will be surrogacy. As Brigadier Sharma sir had said, that is our last option. If we cannot help a patient by building up their endometrium for despite all interventions, then that is what we have to offer to our patients. With that, I end my talk, ma'am and sir. Thank you, audience.
Thanks, Meenu. That was such a crisp and a wonderful talk on the thin endometrium. Probably you have covered A to Z of the thin endometrium, the role of adjuvants, the role of hysteroscopy, and everything, and the newer developments. So I would request Shadajan ma'am and RK sir to comment and give their valuable comments.
At the outset, I must say, Dr. Ahuja, you had done a fair justice to your talk, and you also shared what you practice, and that is what I appreciate.
Yes, ma'am.
Thin endometrium is definitely a challenge in good 20% patient of ours. And I'm happy that you did tell that many adjuvants which we use have a very weak evidence.
Yes, ma'am.
But all said and done, beside getting the diagnostic aspect, the hysteroscopy, and getting to know that there is no evidence of tuberculosis, and if you find on a repeated examination on transvaginal sonography, if the pelvis is clear, then in those cases I find that estrogen majorly helps in about 80% of cases. In our practice we find GCF also
Yes,
helps.
ma'am. Yes, ma'am.
Prior to that I feel that you must definitely get a CBC done, and you must know that TLC and other things and CRP is not raised in such patients.
Yes, ma'am.
And then I find it is definitely hasn't helped. But this can help only when your endometrium, natural build of the endometrium is up to 5 millimeter. If the endometrium built up is not up to 5 millimeter, nothing is going to work. And as far as the PRP is concerned, I think it will only help if the endometrium build-up has been 6 or 6.5. Then it can raise it by 1 to 1.5.
Yes, ma'am.
And in bad cases, I feel whenever we have taken in a bad situation when we said given up, and she says I can't get surrogacy. So in that case, I feel if you do a bone marrow or stem cell installation in such patients, it works wonders.
Yes, ma'am.
And
I saw that when I was with you. You had done.
it does wonder. So we have had 3 4 cases, but that makes it treatment very expensive, and that is why this has gone in favor of PRP. Since the time I will say that in case if PRP is needed, one should do autologous stem cell transplant in such patients. We had initially 3 patients of ours had a very wonderful results, but subsequently I've not been able to convince, because the market is so much, that everybody says I can do it with the PRP. I said, okay, go ahead with them, and go ahead. But I feel this is my limitation. But I will definitely say that tuberculosis need to be ruled out. Pelvis on this thing on repeated ultrasound should be absolutely clear. And in case if there is a need be, I have nothing additional to say. We use Sildenafil, but we have given it up. Everything we have given it up, because people say, and I'm happy to see that that Ashray also has said. I will love to hear what Brigadier Sharma has to say. And now we have Dr. K.D. Nair. Will have his opinion also. Over to you, Brigadier Sharma.
Thank you, madam. Thank you, Dr. Meenu, for a nice talk.
Thank you, sir.
Yeah, and you covered all the aspects of thin endometrium. Now, basically, when we see thin endometrium by ultrasound, we have to look into the ultrasonic, morphology of the endometrium. If you find, triple layer thin endometrium versus a ecogenic thin endometrium,
Yes, sir.
so firstly we should differentiate between the two.
Hmm.
If it is a thin layer, triple layer thin endometrium, this is the one which is going to respond to your treatments.
Okay, sir.
Okay, with add-ons, whatever you are saying.
Yes, sir.
The one which is ecogenic, that is the one which would fail to grow, even whatever you add, whether you add Sildenafil, whether you add GCSF, PRP or not. So when we are looking at the endometrium, we should see what is the ultrasonic morphology of the endometrium, and based on that, we can decide whether this is going to work or not going to work.
Yes, sir.
Secondly, when we give estrogen from outside for preparation, now there are two molecules, valerate and hemihalate.
Yes, sir.
So sometimes you find that the patient, most of the time we are using valerate instead of valerate, and the patient doesn't work with that. You change to hemihalate and you find that the endometrium grows.
Right, sir. Right.
Yeah. So that is
Yes.
the receptors, they prefer that particular molecule. Or if both of them don't work, then we say go for a natural cycle or even a stimulated cycle, mild stimulated cycle
Yes.
to the endometrium. So that would be the next step.
Yes.
And the another thing which is, which we miss, and the patient most of the time, they think now the doctor is going to do the IVF and we don't have to do anything. We give the medicine and we take it and do ultrasound. There is a good role of intercourse to develop the endometrium. Now, how it works? Firstly, the semen is having high content of prostaglandins.
Okay.
So when they have a regular frequent intercourse, So the more prostaglandins are being released into the vagina, and some of that would go into the circulation.
So, sir, during this cycle that we're preparing the lining, we should ask them to be together.
Yes, 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 yes.
Okay.
So that the that would cause uterine contractions also, and that would increase the blood supply also. And there was a
Right.
paper recently, where they studied two group of patients where before IVF they were allowed to do intercourse, and another group where they were not allowed to do intercourse. And they found that the success rate, was more where they were allowed to have an intercourse. So this is very, very important that we should, allow them to have in fact, we should encourage them.
Right.
Otherwise, because of infertility, years of trying, they think it is, useless. Now they don't have to do anything. So that is very, very important,
Just
I
to
find.
take away, sir. Okay, sir.
Yeah. And then, we are giving what I in my practice, I find that we give L-arginine orally, or, but there is the gel which is available, the Hemeract gel, L-arginine gel.
Okay.
So, I tell the patients, to take gel up to the, one part of the finger, and then put it inside the vagina. And I have seen, they do better in comparison to when we give them orally. So L-arginine gel is available, so we can give them that also.
Right, sir.
And rest, we have to also be very careful. And most of us would know before doing IVF whether there's any Mullerian defect also or not. Under those circumstances, you can make a mistake of, this thin endometrium may not be thin endometrium.
It's this side, I not.
That normally is always excluded before we start the IVF program.
Yes, sir.
So in nutshell, the thin endometrium, see morphology, if it is triple layer thin, it is more amenable to your treatments. And if it is echogenic thin endometrium, maybe you require to do hysteroscopy and see if there's adhesions or whatever it is. Sometimes you will not see even adhesions also. You may see subendometrial calcifications with thin endometrium. That is the worst endometrium,
Yes.
which doesn't work at all.
Right.
So if you have a nice thin endometrium with triple line, without any subendometrial microcalcifications, so that is the one which we are hopeful that yes, something will work on them. But one with having microcalcifications and it's echogenic endometrium, that is the one which is not
Resistant.
amenable to the treatment. So finally, because the surrogacy has become very difficult now. So poor patients, they cannot afford. So they are the real challenge. So sometimes I tell my patients, the pregnancy can occur in the ovary, there is no endometrium. It can occur in the fallopian tube, there is no endometrium. So the uterus, it may not be that the whole of the uterus is bad. There may be some areas which are healthy, like in a, if you are from a village, some areas hard with a stone, and some is
Focally, it might be better.
So and under those circumstances, instead of 2 blastocysts, you may transfer 3, and make a note also why you made it, because now it has become a problem that you can't
Mandate.
transfer more than
Yeah, we have to
yeah.
do
Because
minimum of.
here when it was not the case, because we used to get a lot of patients from army where the endometrium would be thin and they could never think of doing adoption. I have put 5 embryos in that, and some of them did become pregnant even with say 3 or 4 millimeter echogenic endometrium also. So, but now we can't do that. So the maximum we can do transfer blastocysts and transfer this or do transfer 3 blastocysts and mention in the case sheet why you're doing it, because suppose in case the authorities ask you, you know the reason before that.
Right. Thank you, sir.
So, sir, I
So,
think your today's comments definitely tell that today is going to be a shift. If you say that in stimulated IVF cycles, if you advise them to have relationship, I think that's everybody who's listening. It will be a surprise to everybody. That trend has to change completely. Dr. Sunita, are you there?
no, Dr. Sunita is not there, ma'am. So this is the new thing we have now.
Dr. Nair, you want to make a last minute comment?
KD sir. So you're muted.
Yeah, Dr. Sharda, thank you. See, I was busy with some papers, but I think what Dr. Brigadier Sharma has said, I agree with him. That is the think it has to be followed.
Okay, sir.
Hmm.
And Dr. Suveen, your experience, please. Dr. Suveen, are you there?
Yeah, I'm there.
Okay.
So,
So,
yeah, definitely, thin endometrium is a dilemma. I think she covered it very well, Meenu. And I feel that Jan, that stem cells may be the answer, but there are so many blocks coming in the way. Even for PRP, there are so many blocks coming in the way. Experimental, just that label that it's experimental is enough for the patient to be put off. So somewhere we need to all collect and get together as a force to be able to initiate these new treatments into our clinical practice as a routine, so that we can carry out some randomized trials and bring out these practices in a relevant manner. That's what I feel, that they're coming, but we're just doing sporadic cases. One case walked in, we did it. Second case walked in, we did it. But if we actually get together and do RCTs, it would be a great publication. It would change practice.
yes.
Dr. Surveen, I will must say, tell you that I have remained a teacher for such a long time. But ART is one area where nobody can predict.
Yes, I agree.
Nobody can predict. सब
I
बिल्कुल ए सारे में फिर भी वो नेगेटिव है और जिसमें कुछ भी नहीं है, जीरो है, तो
yeah.
पेशेंट प्रेगनेंसी टेस्ट कराती है पॉजिटिव. So
You're
I
so
think
right in this.
Actually, what we can do is we can only make the bodies. We can't put a soul into that. That is our destiny.
Yes.
Like I tell the patient, we can make the embryo, we can't make the baby.
Yeah, very rightly said. So basically, in thin endometrium, I think the one thing works best is if there is a history of DNC and then Asherman syndrome. If you do a good hysteroscopy, that is the area where I've seen the endometrium beautifully comes up. But yes, if the basal layer is gone, then even after the hysteroscopy, the endometrium will not come up. Then there comes the role of all these stem cells, PRPs, and GCSF. But still with no consensus as of yet. So, with this, such interesting discussion on thin endometrium, which I know can go on and on, we move on to a very another interesting topic, that is chronic endometritis. And for that, my pleasure